everyone, Mike Biamonte, FBI, School of Operational Medicine. Welcome again. This is video number 12 of a unknown amount of videos upcoming. We're going to keep on doing these until I can't do them anymore or run out of, I don't know, I can't imagine I run out of topics. But what we're going to cover in this video is cardiology. And it's probably going to be a multi-series. Cardiology is such an animal. It really is. So we'll start off with anatomy and physiology, go figure, and really get into some of the nooks and crannies of anatomy and physiology. Most of it will be BLS. There'll be some high-speed stuff in there on the ALS level. So if you BLS providers, just kind of hang in there through it, and I'll make it understandable as best I can. And the next series, or the next video, maybe 13 and 14, we'll probably get more, I shouldn't say probably, we will get more into different diseases, from MI to acute coronary syndrome to angina, acute pulmonary edema, CHF, yada, yada, yada. And we'll then start to transition into assessment and treatment of these patients. Now, most of what we're going to talk about in those videos is at the BLS level, but we'll start to talk about some ALS care as well. For the paramedics in the group, we're going to transition into advanced care for the cardiac patient. I may end up doing a video on basic 12-lead interpretation, which is typically an 8-hour class that I do, but I'll kind of bring it down to the Cliff Notes version. We'll also do an ACLS review of the highlights of ACLS. So these are forthcoming videos dealing with cardiology. So cardiology really is an animal. It's a big, big topic. So I figured I'd tackle it up front, and not to say get it out of the way, but really talk more about it. Boston, all right. Got Boston represented today on the shirt. I had a great time in Beantown last year, the year before. I'm sorry, I forget where I've been when I've been there. But love me some Beantown. Had a lot of fun there. Again, great feedback on these videos. Everybody seems to be enjoying them. Keep it up. Keep watching. I'll keep putting them out for my FBI folk. I keep on uploading the classes into NREMT for you, so just sit back and watch the videos and enjoy them. And any questions you have, just let me know. We'll kind of take those as they come. Nothing sensitive, nothing classified, all easy stuff. Let's talk about cardiology. Let's talk about people, how they have and why they have cardiac events.
I've never had pains like this before. Oh, this is the worst one I ever had, son. Oh, it's the worst one. This is a big one. I'm dying. You hear that, Elizabeth? I'm coming to join you, honey. Oh. Maybe that's Elizabeth.
There's a little flashback for you. A sitcom from 70s, 80s? I don't know. Old Fred Sanford. Have you ever got a chance to see Red Fox do his stand-up routine? Ooh, he's crude. Funny? Oh my God, is he funny, but crude. Okay, let's go ahead and get started with anatomy and physiology of the heart. We talked about AMP of the heart in the first video or the second video of AMP review, and we really did a broad stroke overview. So we're going to hit those points again, but we're going to dive a little deeper because, again, the understanding of anatomy and physiology when it comes to the care of your cardiac patient is invaluable. You have to understand how the cardiovascular system works. For the ALS providers, you have to understand all the way down to the myocardial cellular level. You have to understand electrolyte movements, repolarization, depolarization, and we're going to touch on that later on in the video today, because that leads us into EKG interpretation, pharmaceuticals, those sorts of things. So unless you've got a good foundational understanding of cardiology, even at the cellular level, as an ALS provider, you can't really provide adequate understanding and care for your patient. From the BLS level, remember, it all comes down to recognition of a sick patient. That's what it all comes back down to. Sick, not sick. So the cardiac patient, this is kind of putting the cart before the horse here. I don't want to talk about assessment too much. But if we're looking at a patient, knock on wood, right now I could be having a heart attack. It could be very mild. It could just be a little bit agita, a little bit of heartburn. I don't feel right. That could be a heart attack. All the way to, Fred Sanford doing one of these and clutching their chest and falling to the ground. It could be anything in between. So at the BLS level, when we look at our patients, somebody who just says, I don't feel well, could be a heart attack. Now, I don't want you to knee-jerk and panic and think everybody who doesn't feel well is having a heart attack. We'll get more into that in the assessment section of cardiology. But for now, let's go back to cardiology. Let's go back to just basic anatomy and physiology. So let me put this slide up. And we'll kind of work our way from outside to in. We've seen this picture before. This is the basic concept of your heart. Heart sits right in the middle of the chest, right below the sternum. The apex of the heart, which is ironically the bottom. The top of the heart is actually called the base, which makes no sense to me, but that's just the way they've named it. The top of the heart is the base. The bottom of the heart, where it comes to that point, is called the apex. So the apex of the heart in this picture here, where it says left ventricle, is actually tilted just a little bit to the left, which is why when we were kids and we would do the Pledge of Allegiance to the flag, we'd put our hand over our left side of our chest, saying that that was where our heart was. Now, truly, our heart is not on the left side of our chest. It lies right beneath our sternum, but it is tilted just a little to the left, and that's the reason why people always thought it was on the left side of the heart. So your aorta is your monster. That is your main thoroughfare, your main pipeline. We'll talk a little bit about that later on as far as different problems that could occur. Inferior superior vena cava, just to the left of the aorta, that is your deoxygenated blood coming back from above your shoulders and below your shoulders, essentially, and coming into the right atrium. Your right atrium comes down, and we'll see a cutaway of this in a second. Right atrium comes down to the right ventricle, out through that pulmonary artery. And remember, for those of you going to take a test maybe here in the near future or refresher exams, who knows, one of the only arteries in the body that carries deoxygenated blood, because arteries carry blood away from the heart, away, is your pulmonary artery. Pulmonary artery takes blood to the lungs, gets oxygenated, comes back via the pulmonary veins. Again, test question, one of the only veins in the body that carry oxygenated blood, your pulmonary veins. Back into your left atrium, down to your left ventricle, out through your aortic valve into your aorta, and through the rest of your body. So that's, in general terms, your heart. Okay, when we look at the outside of it. So let me change this slide. And continuing on the outside of it, look at coronary arteries. Now, coronary arteries for the BLS provider, well, really, not to say it doesn't mean much to us, don't misunderstand. But this is more for the ALS providers when we start giving vasoactive drugs, such as nitroglycerin as an example, or Tridal in your drip form, or any drug that's going to decrease preload by vasodilating. And we'll get more into that later. This is where we're going to have our effect, hopefully. And when we talk about atherosclerotic heart disease and plaque buildup, when we get into actually disease processes in the next video, these are the blood vessels we're talking about. So the blood that's actually coursing through your atria and your ventricles, very little, if any, of that blood and that oxygenated blood gets absorbed in that myocardial tissue to perfuse that muscle. It just doesn't happen. We get, or the heart gets, its oxygenated blood from these coronary arteries. And coronary in Latin actually means crown. You would think it means heart, but nope, you'd be wrong. I was wrong. I thought coronary meant heart for years. But it actually means crown. Because if you look at the way the coronary arteries cascade down the outside of the heart, it looks like a thorny crown. So, again, that and $2 will get you a cup of coffee. So we look at the left and right coronary arteries as they come off of the aorta. That is the first bifurcation off of the aorta, is your left and right coronary arteries, which becomes important when we start to talk about a scenario known as SVT, supraventricular tachycardia, because the valves of the aortic valve, when they open during ventricular systole, and we'll talk about that here in a little bit, actually cover up the opening to the left and right coronary arteries. And it's these coronary arteries that cascade along the epicardial surface or the outside of the heart and perfuse the myocardial tissue. So Mother Nature's pretty crafty. She takes the most oxygenated blood for herself for the heart, to perfuse the heart, which is really pretty remarkable. And we'll get more into that later. So when we talk about plaque buildup, an atherosclerotic plaque buildup, hardening of the arteries, these are the arteries we're talking about. These are the coronary arteries. Let me put another slide up here. Here's your cutaway. And this is your traditional cutaway that we always see in the cardiac world. Truth be told, your atria are not that pronounced. Your atria kind of sit flat and floppy. There's not much to them. I was actually surprised the first time I ever held a human heart in my hand in a gross anatomy lab. Initially I had a hard time finding the atria because I was expecting a diagram like this. I was expecting big open chambers, and the atria are kind of floppy. They don't do much. And truth be told, in Willy Wonka world, if you chop the atria off and completely discarded them, which I don't know why you would do that, you would still be able to live. The ventricles are the workhorse of the heart. I don't remember the exact numbers, but I want to say the atria really only contribute about 10 to 15% of cardiac output by what's called the atrial kick. So if you remember from one of the first videos, we talked about the heart pumping action, and we'll show a video here in a second of that, where we see the atria contract and the ventricles contract. Atria contract, ventricles contract, sort of a top-bottom motion. And that top squeezing down, the atria, the atrial kick as it's called, squeezing down, contributing that 10 to 15% of blood to cardiac output, that's really all it does. So people who suffer from atrial fibrillation, when the atria just quiver and really don't do much, other than the risk of clots and a number of different things that we'll talk about later in other videos, the atria don't contribute much to cardiac output, to general circulation, but these patients walk around just fine. They walk around every day, they're on medication, they're on anticoagulants, they're on a number of different things, blood thinners, but they live a very full life. So that's the atria. So if we look at this picture here, we look at the right atrium, and as we come down through the right atrium, we go into the tricuspid valve. So remember rat and lamb we talked about in another video? These are your AV valves, your atrioventricular valves. So the valves that separate your atria from your ventricles, your AV valves, rat and lamb, right atrium, tricuspid. Right? And if we move over to the left side, left atrium, mitral or bicuspid. So it could be called one of two things on the left side. If you look at those hair-like structures just underneath it, and it's actually labeled on the left side, it's called chordae tendineae. Your chordae tendineae and your papillary muscles on both sides, left and right, are what attach to your AV valves and promote the opening and closing of these valves. So in a situation very commonly known as mitral valve prolapse, right, with a mitral valve prolapse, you get what's called a heart murmur. In a lot of scenarios, what ends up happening is the endocardial wall, and we'll show a slide here in just a second, but the endocardial wall, or the inside wall of the heart, where the papillary muscle resides, if that patient is suffering an endocardial wall MI, so where that inner wall is suffering from hypoperfusion, lack of oxygen, and damaged tissue, that papillary muscle will weaken, and the effect it has on those valves becomes diminished. So now what ends up happening is during ventricular systole, when the ventricles contract, the papillary muscle isn't strong enough to hold on to one of the flaps of that valve, and the flap regurgitates and prolapses and pushes up into the left atrium, as an example. And what ends up happening now is blood whooshes backwards in a retrograde fashion up into the atria, past that weakened flap of that valve, and we get a murmur. When we're listening to heart sounds, we'll hear a whooshing sound, and that's a heart murmur secondary to a mitral valve prolapse. A lot of people walk around with this every day. It's normal, it's a variant of normal for them, they deal with it, it's not a big deal. Other patients actually have to have it surgically repaired. So that's just a little bit about those valves. So as we work our way down into our right ventricle, we exit through the pulmonary valve into the pulmonary artery, as we said before, to the lungs, oxygenated, comes back to the pulmonary veins. I don't like the way this is colored because those veins should be red, but that's my little pet peeve there. Comes to the left atrium, down through the mitral valve, into the left ventricle, out through the aortic valve, and into the aorta. And in this picture, I don't like the size differential between the left ventricle and the right ventricle. The left ventricle is a monster. It's a big walled chamber. Well, the right ventricular wall is pretty floppy. There's not much to it because it only has to push blood to the lungs, whereas the left ventricle has to push blood to the entire body. So that's the workhorse right there. If you look, you see what's called the fossa ovalis in your right atrium. That was once a hole between your right and left atrium. So when we were inside mama, right, we were in utero and we were cooking, so to speak, and being developed. As I said before, the Abyss had it all wrong. Right? The movie The Abyss said you breathe fluid for 9 months, your body will remember. Right? Horseshit. We didn't breathe fluid for 9 months. That is not how we roll. All the blood being pumped from mama into us while we were in utero bypassed our lungs because they were non-functional. So when blood came into us while we were still inside mama, came in through the superior inferior vena cava, came into the right atria, but it passed through that ductus arteriosus, or rather that foramen oval, or it was called at the time, or that hole between your right and left atrium. And then from your left atria, it dropped right down into the ventricles and got pushed out to the rest of the body. So it avoided the right ventricle altogether, thereby avoiding not lung perfusion, but pushing blood to the lungs altogether, because our lungs were non-functional. Now, in the event that some of the blood did make it down to the right ventricle, it did get pushed into the pulmonary artery. But what you don't see in this picture here is, follow me along here for a second, look at the pulmonary artery as it comes up out of the right ventricle, right where it bifurcates and splits into left and right. What you don't see is a structure called the ligamentum arteriosum, a connective tissue. It actually connects and anchors the pulmonary trunk or the pulmonary artery to the aorta. That used to be a blood vessel. It used to be a structure called a ductus arteriosus. So in utero, if any blood made it down to the right ventricle and got pushed out, intended to go to the lungs, it couldn't make it there, it would actually get pushed into this blood vessel and get pushed right into the aorta, so bypassing the lungs altogether, which is really pretty fascinating. After we're born and the doctor smacks us on the ass and we take our first breath, what ends up happening to that ductus arteriosus is I don't want to say calcifies, but it firms up and constricts down, so it's no longer a patent blood vessel, but it becomes an anchoring point called the ligamentum arteriosum. And the only reason I bring this to your attention is in deceleration trauma, heavy chest trauma, what will end up happening sometimes is the heart will swing like a pendulum during big deceleration trauma. Falls, hit by a car, you're in a car accident, that sort of thing. And that ligamentum arteriosum that's anchored to the aorta will pull away from the aorta and shear that aorta wide open and kill you dead in a second. It's called a shearing injury. It's not something that we would see in our patient necessarily because it's going to be internal, but this is secondary to some pretty significant chest trauma. So I just think that's pretty cool. I guess it's not cool if it happens to me, but cool nonetheless. So let's go ahead and put another slide up here. And let's look at the cutaway of the different layers: epicardium, myocardium, endocardium. And I also want you to take notice here as to where your coronary arteries reside, where they run. They run along the epicardial surface just beneath that visceral pericardium, or right beneath that fibrous pericardium. So your heart sits in a sac. Right? Your mediastinum, your pericardium, your visceral pericardium, pardon me. Your heart resides and sits in this sac, and it's surrounded by pericardial fluid to allow for lubrication. And when we talk about pericardial tamponade, and we talk about fluid in that space secondary to trauma or infection or disease, this is the space that it resides in, is that pericardial cavity. And that creates a lot of problems, to say the least. But your coronary arteries run just underneath that fibrous pericardium. which also tends to be problematic. Now, if you think about it, if somebody's heartbeat in SVT is going at about 200 times a minute, that heart is constantly being squeezed, and it's also squeezing those coronary arteries, not allowing for those arteries to perfuse that myocardium, which leads to chest pain, and so on and so on. And we'll get more into SVT in another video, but I just want to give you situational awareness as to where those coronary arteries reside. And at a certain point in time in their life, they will sort of right angle dive down in through the myocardium and all the way down to the endocardium, which is the innermost wall. So when we talked about papillary muscles before, and we mentioned endocardium, that's sort of where your papillary muscles reside, and your chordae tendineae attached to those, and those strings, literally strings, attached to your AV valves. You can have endocardial wall heart attacks. You can have myocardial wall heart attacks, so MI, myocardial infarction. So when we talk about MIs, that big meaty part there that you see in the center, that's what we're talking about. We're talking about MIs. And there's transmural MIs, which means it's a heart attack that encompasses your endocardium, myocardium, and epicardium. It's a full thickness MI. And you'll see different EKG changes with that for the ALS providers in the room. All right, so let's go ahead and pull this slide down. So that's a lot of information about the anatomy and physiology, and it really isn't a lot of information because we haven't even gotten into the cellular stuff yet, and we'll talk about that here in a minute. So structurally speaking, we looked at the valves. We looked basically at the blood flow through the valve. We looked at the chambers. I apologize. We looked at the chambers. We looked at the valves also. We looked at the blood vessels coming into and out of the heart. We looked at the layers of myocardial tissue and some of the problems that you might see. So in later videos, we'll talk more in detail about the different pathology and, of some of these diseases that you'll see in the cardiac world. So now the pumping motion, our cardiac output. So I'll put this slide up here. Again, very basic, and this is one of the videos that I showed in one of the first couple of videos. So what I really want to reinforce here is the systole and diastole. So if you look, it shows a little lub, a little dub. Okay, those are your valves opening and closing, making those noises. But if you really pay attention to it and you look, you'll see the atria squeeze, the AV valves open, right? The AV valves close, the ventricles squeeze and force those AV valves shut and pushes blood out through your pulmonary artery and your aorta, and it just repeats over and over and over again. And this is that top-bottom type of perfusion that we talked about, or pulsing motion. So systole, there is an atrial systole and an atrial diastole. We normally don't refer to those. Again, I'm not a cardiologist. I'm not here to make you a cardiologist, that's for damn sure. But when we talk about systole, it's assumed that it's understood that we're referring to ventricular systole, ventricular diastole. So systole, again, is that ventricular squeeze, pushing blood out through the pulmonary artery and the aorta. When we talk about diastole, we're talking about the relaxation phase of the ventricles, that blood filling up those ventricles from pulling it down from the atria and kind of waiting for systole to occur again and push that blood out. This is what's going on in our heart 24/7, and it continues, ironically, until the day we die. So let's go ahead and pull this down. So that's your pumping motion. Lub-dub, your valves opening and closing, and even at the ALS level, for years I've learned about heart tones and S1, S2, S3, and S4 heart sounds and murmurs and gallops and all the other different terms. Pre-hospitally, I can probably count on one hand the amount of times I actually really consciously listen to somebody's heart sounds to help me in the care of that patient at the ALS level. Now, if you're in the critical care world and you're in hospital, ICU, CCU, yes, absolutely, there's a place for heart sounds, absolutely. Pre-hospitally, in my opinion, I've never really done it. It's never changed the way I've treated my patient. It's a complicated skill to learn, not to mention you really have to have a quiet environment and a good stethoscope to sit and listen to those things. So that's my 2 cents on heart tones. So we talked about the beating motion and cardiac output. So let's go back to those equations. Remember those equations that I put up? And I said you were going to see them again, and I was going to haunt you with them. I'm going to make them bigger this time so you can see them. So here are those slides, or here are those terms. All right, so cardiac output. I'm going to beat you to death with this. Cardiac output equals heart rate times stroke volume. All right, that is paramount. So if we looked at that video I just had up there, the little slide I just had up there as far as that pumping motion, right? That beating of the heart, the amount of blood ejected from the ventricles with one contraction is stroke volume. So cardiac output equals heart rate times stroke volume. And once again, I'll say it, just because your heart rate is fast doesn't mean that your cardiac output is good. It could just be the opposite. Because if you're tic-tacking away at 200 beats a minute, you have no preload. Right? Preload is end diastolic volume, the amount of blood in the ventricles at the end of diastole available for contraction or available for ejection. So if your heart rate is so fast that you cannot refill your ventricles, well, your preload is crap. If your preload is crap, well, now your stroke volume is crap. If your stroke volume is crap, your cardiac output is crap. So fast isn't always necessarily better. In the cardiac world, we typically use a number of 150 to 160. 150 to 160 beats per minute or higher is, technically speaking, supposed to be SVT or supraventricular tachycardia. I don't like hard numbers necessarily, but that's the general rule. Bradycardia is just the opposite. If your heart rate is less than 60, technically, that's bad. I don't rely on hard numbers. If you're an athletic person and you're a runner and your resting heart rate might be 40, does that mean you're sick? No, quite the contrary. You've got a good, strong heart. And at the end of that diastolic phase, at end diastolic volume or preload, you've got a ton of blood in those ventricles, and your heart is strong enough to be able to push out all that blood with one contraction, so your stroke volume is just fine. So albeit your heart rate may be slow, doesn't mean your cardiac output is affected. It just means you have a very, very athletic heart and you're doing just fine. Now, if I'm 80 years old and not in good physical condition and you put me at a heart rate of 40, it might be a different scenario altogether. Now my heart rate is crap. I don't have a strong heart. I can't push out a lot of blood and my cardiac output falls. So now with blood pressure, cardiac output times peripheral vascular resistance, or in some books you'll see it listed as systemic vascular resistance, SVR. We have to understand what cardiac output is. So now we know what cardiac output is, and now we can plug that into blood pressure. So if we're looking at someone's blood pressure and their cardiac output is crap for whatever reason, well, their BP is going to fall. If their peripheral vascular resistance is increased, say because of a sympathetic tone response, epinephrine, nicotine, drugs, some stimulants of some kind, and we have vasoconstriction, now we have a decreased container size. The ventricles have to push harder against that narrowed lumen of those blood vessels of that container. Well, that's a decreased, or increased rather, peripheral vascular resistance. Well, that brings my blood pressure up. And quite the opposite when we start talking about vasodilators, like nitroglycerin as an example. Give somebody nitroglycerin, now they vasodilate. Now we've actually decreased peripheral vascular resistance. For the firefighters in the room, it's basic hydraulics. You're going from a booster line or an 1 3/4 line to a 1.5 deuce or a 5-inch hydrant line. Right? It's just reduced friction. Right? We talk about your friction of your hoses based on the diameter. This is basic hydraulics. So the more narrow your blood vessel, the higher the resistance, the higher your blood pressure. So these are the equations that we like to rely on, or I like to rely on, when I talk about cardiology and pharmacology and perfusion in general. So I'm going to go ahead and pull this down. Now, the blood vessels, talking about the blood vessels, and we talked about vasodilation and vasoconstriction. This becomes important in cardiology when we start talking about different drug therapies. Epinephrine as an example for a vasoconstrictor, nitroglycerin as a vasodilator. But we also have to understand blood vessel anatomy, not just aorta to artery to arteriole to capillary to venule to vein to inferior superior vena cava, okay? That's nice, don't get me wrong. But we also have to understand the layers of the blood vessels. When we start to talk about aneurysms as an example, or varicose veins as an example, excuse me, we have to understand those levels. So let me go ahead and put this slide up here. And you've seen this slide before. I think it's a pretty detailed and descriptive slide. But if you look on the left and you look at an artery, you're looking at tunica intima, tunica media, tunica externa, or tunica adventitia, depending on what book you read. When we start to talk about aneurysms, as an example in the next video, we have to understand where that aneurysm, or more specifically, where that false blood flow of an aneurysm occurs. The best way to describe it, in my opinion, is a garden hose. Take a green garden hose, doesn't have to be green, but traditionally a green garden hose, and cut it in half, like a transection of that hose, and look down the lumen of it. What you'll see is the green outer layer, right? That's your tunica externa or tunica adventitia. Then you have this fibrous kind of white inner lining. Well, that's your tunica media. And then you have the black inner hose. Well, that's your tunica intima. What you have to try to imagine during situations where somebody has extreme atherosclerotic plaque buildup, hardening of the arteries, and they crack this plaque, now you can actually have false passage in between the tunica intima and the tunica media. So in that garden hose, imagine you have a crack in that black inner lining, and now as water is being pushed through that hose under high pressure, well, now it forces its way between the tunica intima and the tunica media and actually creates a false passage. This is what gives that patient that tearing sensation we typically hear about in patient presentation with aneurysms. And like I said, we'll talk more about that later. Your veins, on the other hand, are far less muscular. They have valves where your artery doesn't. And not to say that there's not many problems that we're going to deal with on the EMS side of the house when it comes to veins. It's more arteries that we're concerned with. But with varicose veins, we can have an aneurysm or an outpouching of the vessel wall of a vein. Usually it's in the legs, lower legs. And they'll rupture these balloons and bleed like stink. I mean, you walk into somebody's house who's had a varicose vein pop. I mean, there's blood everywhere. It's like a massacre scene. It's unbelievable. Can they bleed to death from these? I'm sure it's possible. I've seen some sick patients because they've lost a good deal of blood from varicose veins rupturing. I've never seen anybody die from it. Not saying it hasn't happened. I'm sure it has. I haven't seen that. All right, so let's pull this down. And let's talk now about the electrical conduction system of the heart. How does the heart beat on its own? That in and of itself is fantastic. And I always talk about, we talk about somebody who goes into cardiac arrest, and you talk about ventricular fibrillation and all the things that we're going to talk about in later videos, more for the advanced providers. One of the things that went away in ACLS care was the cardiac thump. All right, so let's see the cardiac thump.
Everything okay? No problem, just having a heart attack. Almost over. Done. Very good.
Saturday Night Live, you can't go wrong with that skit. I love that skit. But when he's doing this, right, and I'm here to tell you, all right, the science is going to say otherwise, and AHA is going to say otherwise, but I have thumped patients who've gone into cardiac arrest right in front of me, and it brought them right back. It worked. Now, I'm not advocating for that, okay? I'm not going to say, oh, your protocol is wrong, AHA is wrong. Who am I? I'm a lowly old paramedic. What do I know? I'm telling you, I've had patients go out right in front of me. They've gone, oh, I don't feel good. Ugh. They go out, I look over at the monitor, and they're in what's called ventricular fibrillation. They're just zipping along, and boom, I hit them in the chest, and they sat back up, and they were pissed off at me because I hit them, and they knew that I hit them, and they asked me why I hit them. I said, well, you just went into cardiac arrest. Well, they don't see it that way. I had a guy do that to me a number of times, transporting to a hospital. Matter of fact, of all the hospitals in the world, I think it was Mary Immaculate Hospital. It doesn't exist anymore. It was in Jamaica, Queens, and New York. A real rose petal of the world, I'll tell you. But he kept on going out on me, and I kept on hitting him. Because every time I would turn around to grab the paddles, we didn't have pads at the time, we had the old paddles, he would go back into it, and I'd hit him again. I must have hit this guy about 5 times. I wheel into the ER, and I tell the staff what I did. And of course, the doctor's poo-pooing it. He's like, no, you didn't do that. Oh, no? And sure as shit, almost like it was on cue. It was perfect. The patient goes, ugh. And boom, I hit him again. And he comes back, and the doctor says, oh my God, it really did. So it's just kind of funny how it worked. I'm not telling you to beat the crap out of your patients if they go out on you. I'm just saying, in the electrical conduction world, there's something to be said for that treatment. So if we look at this slide, here's our electrical conduction system in a nutshell. We have the SA node, the AV node, your bundle branches, and your Purkinje fibers. For the ALS providers in the room, now we're getting more into electrical conduction, EKG interpretation. The fascinating thing about the heart is that it has the ability to generate its own electrical impulse, a condition known as automaticity. So any other muscle of your body has to be stimulated by an outside electrical source, all right, a nerve ending, to do its thing, to bend your arms, for me to flap my gums and talk. I need that outside stimulus from a nerve ending to stimulate those muscles. The heart doesn't need that. Technically speaking, you can pull the heart out of, I think it's a chicken as a matter of fact, if I'm not mistaken, or certain animals, you pull the heart out, that heart will continue to beat for a while without electrical stimulation from an outside source because it's still supplied by blood with electrolytes and oxygen and so on, which is pretty cool stuff. Our heart is kind of similar to that, to where we pull it out of and I've read books, obviously I've never done this, but if you pull a heart out of I think they call them, what do they call them? Cadaver donors or something like that. These are people who are brain dead, but their heart is still beating, and they actually pull the heart out of their chest while it's still beating, so to speak, for organ transplant and to bring them to a different patient. That heart is still beating when it pulls out of their chest, which is really kind of wild. So let me go back to get on point here. SA node, sinoatrial node, that is your dominant pacemaker site of the heart. That is the dominant site, and that's why they call it the dominant pacemaker site, because it has an intrinsic rate of 60 to 100, which means that 60 to 100 times a minute, this area is going to discharge electricity, recharge, and discharge it again. And it's going to dominate all the other electrical cells in the heart, because all myocardial cells, in my opinion, are nothing but little batteries. It's all they are. All these batteries do, all on their own, because of the way they're bathed in an electrolyte solution, being blood, they discharge or depolarize and recharge or repolarize. That's all these cells do. But they all suffer from what's known as the all or none principle. So the thing that's fascinating is if you look at this picture, this diagram, all it takes is one myocardial cell within that SA node to depolarize. One tiny little microscopic cell has to depolarize. What ends up happening is that creates a chain reaction, kind of like knocking over one domino. All the others have to fall, the all or none principle. So once one single myocardial cell in that SA node discharges or depolarizes, every surrounding cell will do exactly the same thing, and it'll propagate along that chain, which is why when the SA node discharges, it goes through the internodal pathways to the AV node, from the AV node down into the bundle of His. From the bundle of His, it goes down through the bundle branches. From the bundle branches, it flares off into the ventricles, into your Purkinje fibers. So it follows that natural chain of events until the entire heart has depolarized. And then for a fraction of a little bit of time, a second, who knows what, well, the SA node is going to kick off again. And the whole thing is going to start all over again, constantly, 60 to 100 times a minute. So even if there was an area of the heart, say the AV node or the ventricles, that are desperately trying to hurry up and repolarize so they can be the first ones to go, 9 times out of 10, the SA node is going to win because that area recharges and discharges the fastest, which is why it's a dominant site. When you start getting into cardiology and you start looking at EKGs, you start to look at different situations to where the AV node will fire first, or the Purkinje fibers will fire first, and you have PACs and PJCs and PVCs, which are premature atrial contractions, premature junctional contractions, premature ventricular contractions. You get into different types of ectopy or extra beats. And that's getting a bit further down the rabbit hole for the advanced stuff that perhaps we'll start to talk about in a different lecture. So let me pull this down. Now we're going to spend the next few minutes talking about some high-speed shit. So for the BLS providers in the room, put your hats on, strap in. For the ALS providers in the room, strap in. This is a review of what you probably hated to review in paramedic school, but we're going to touch on it real quick. Just to kind of blow the dust off and get you up to speed. So what I want you to imagine now is one myocardial cell. That's it. One myocardial cell that happens to be sitting in the SA node, all right, the electrical conduction cells. And at a certain point in time, it is sitting neutral. What I mean by neutral is there's a lot of potassium inside the cell, there's a lot of sodium outside the cell. That's the way the cell likes it. But remember we talked about in pathophysiology, that's not the way Mother Nature wants it. Mother Nature wants homeostasis to occur. All right? So we talk about positive and negative charges. As a general rule, remember, we talk about cations and anions. Cations are positively charged ions, where anions are negatively charged. We're not really dealing with negatively charged ions here. We're talking about positively charged ions. We're talking about sodium and potassium. They're both cations. They're both positively charged. So for the purposes of this discussion, what I want you to try to imagine is that the inside of the cell is more negative than the outside. It doesn't mean that it's totally negative. It's just more negative than the outside. So what you have is called a resting membrane potential. The membrane, the cell membrane here, we have more positive out here, more negative in here. So we have the ability for that electrical charge to occur, but it's resting kind of neutral right now to where it hasn't fired. Well, Mother Nature is going to eventually win. And she's going to start pulling some of that sodium in, pulling some of that potassium out until somewhere, now remember, we're talking about one myocardial cell, one microscopic cell. Somewhere on that membrane, let me go ahead and show you this picture here. Somewhere on that membrane, you start to have a crisscrossing of sodium and potassium, because that's what Mother Nature is going to do. Until eventually what happens is you have a momentary polar change to where now in that little segment of that area of that myocardial cell wall, the outside becomes more negative and the inside becomes more positive. What you have then is an electrical charge, an action potential. And what that does is it takes every sodium channel on the outside of that cell and they open up wide. And this creates this huge influx of sodium into the cell, which creates an electrical charge, an electrical discharge. Well, then a fraction of a second later, those cells or those channels close and other channels open. These are your calcium channels or your slow channels. And then we have an influx of calcium into the cell, and this promotes contraction. Well, what's happening in this one specific cell, at this one particular area of this cell wall, now propagates to neighboring cells and neighboring cells and neighboring cells, and they all have to fire. So all of their sodium channels are opening and sodium is rushing in. Then all of their calcium channels are opening and calcium is rushing in. And this goes down that line and propagates. And a fraction of a second after that happens, well, now your sodium-potassium pump kicks in. And what it starts to do is it starts to kick sodium out of the cell and pull potassium back in. Remember that? We talked about different types of diffusion, and we talked about what requires energy, active transport. So this is your active transport. So now what's happening is all of these cells are switching gears, and they're actively kicking sodium out and pulling potassium back in. But somewhere on one piece of one cell membrane of one cell in the SA node, it flips again. And all the sodium channels open up again. And it happens over and over, every second of every day of our lives. So when we talk about giving patients medications, such as lidocaine, this is a sodium channel blocker. We have calcium channel blockers. We have potassium channel blockers. So verapamil is an example of a calcium channel blocker. Amiodarone is an example of a potassium channel blocker. We already said lidocaine is a sodium channel blocker. So in the cardiac world, when we give these drugs, we're trying to affect the depolarization phase of these cells within the myocardium, which is pretty wild and pretty fantastic. So let me throw this slide up here. And I just threw a lot of crap at you. So let me just throw a little bit more just to put it into perspective. So in this slide, what you're actually seeing is what we call the 4 phases of depolarization. So if you look at phase 0, that upswing is going straight up in the air. What this is a representation and an overlay of a PQRST, an actual EKG blip. This rapid upstroke is all of your sodium channels opening. Because remember, back to that one single myocardial cell, one area on that cell membrane had a polarity shift of now it's more negative outside, more positive inside, creates an electrical spark, if you will, which stimulates that one cell membrane of that one cell for all the sodium channels to open. So now we have an electrical charge around that entire cell membrane, which then transmits itself to every surrounding cell. So every surrounding cell now has to have the same thing happen. All the sodium channels have to open, and this is the all or none principle. Now, everything has to fire in the heart. Once we get up to that plateau phase where it says number 1 and number 2, now you start to see potassium movement. We start to see now in number 2, and number 3 is where we start to now come back, or trying to come back to normal, where sodium is being kicked out, potassium is being pulled back in, until we get down to phase 4, where we're back at that resting membrane potential, where all of a sudden 0 is going to happen again, and this whole thing happens all over. It's what I just described to you in 4 minutes is a 2-week lecture in paramedic programs, at least when I taught a paramedic program. Because until you understand these 5 or 4 or 5 phases of depolarization, and you understand the movement of sodium and potassium and calcium, EKGs just don't make any sense. So it's that sodium influx that creates the electrical charge. These are called fast channels that open. And once these fast channels close around phase 1 to phase 2, now slow channels open. These slow channels opening allows calcium to come in. And it's calcium that is supposed to promote muscular contraction. Right after muscular contraction, now these calcium channels close. Sodium starts getting pulled out, potassium starts getting pulled back in, everything comes back to normal, and a fraction of a second later, the chaos ensues all over again. So if you look at the top part of that diagram, you'll see a P wave, a QRS, and a T. So the first positive hump you see, the little one all the way on the left, that's P wave. What that means is you have atrial depolarization. What that means is that the atria have gone through these phases of depolarization. And we're not really overly concerned with the atria. What we're more focused on are the ventricles. as long as the ventricles are depolarizing and hopefully contracting. Because this is all electrical. Everything we're looking at here in front of us is all about electricity. It really doesn't mean that the heart has actually contracted. In the perfect world, we're hoping it contracted, and that's the idea. But all we're looking at here is electrical activity. So when we look at the big upward peak and downward peak, and then it kind of comes back to the middle, that's a QRS. A QRS is indicative of ventricular depolarization, and in the perfect world, hopefully ventricular contraction. As we move our way to the right, we see a final gradual upslope and downslope. That's called a T wave. A T wave is ventricular repolarization. That's the recharging of the ventricles. So if you look at the overlay from your depolarization wave on the bottom to your PQRST, more specifically QRST, you'll see how your depolarization phase and your electrolyte movements correspond with your QRS and your T wave. So when we start talking about electrolyte imbalances and extreme heat injuries and physical activities, and we're losing potassium, we're losing sodium, and we have to replace it, this is the harm that could be done. If we have electrolyte imbalances all the way down to the myocardial cellular level, this is the devastating effect it could have. It could affect your cardiac electrical activity just by having your sodium and your potassium and your calcium thrown off because of extreme sweating or diarrhea or vomiting. This is what can put somebody into cardiac arrest. So let me pull this slide down. All right, now that your head's about to explode, remember that was a 5-minute overview of your action potential and your resting membrane potential and your cardiac cycle of one myocardial cell. Again, I geek out on this stuff. I love this stuff. I think it's fantastic. But it's unfortunate a lot of paramedic programs don't go into great detail on this, and I think they're doing their students an injustice. Because in order for you to understand the P, QRS, and T, you have to understand those phases of depolarization, or else cardiology will never make sense, and the pharmacology dealing with cardiology will never make sense. So that's my soapbox on that. I think I've beat you up enough for the day. That is anatomy and physiology review for cardiology. And now when we get into the next video and we start talking about different cardiac diseases, we talk about MIs, myocardial infarctions, and pulmonary edema, secondary to left ventricular failure, and CHF, and SVT, and how that things will make more sense because now you understand more about the anatomy and physiology. I know I'm a pain in the ass with A&P, I get it, but you have to understand for those of you who are law enforcement, you're carrying around a weapon, you got to know how that weapon works in order to fire it properly. Same thing here in medicine. We have to understand how the heart works in order to treat it, so if that makes any sense. So I think that's it for the day. I don't want to beat you up anymore. We're at about 55 minutes, so we're a little over where I normally want to be. Thank you again for watching. Let's see what the code word is going to be for this class. Code word for this class is going to be dogs, right? Woof, 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 doggies. So dogs will be the code word for this one. This is the end of video number 12. Thank you again for your time. I'm not sure if cardiology is going to be a 2-part or a 3-part series. We'll see how it goes. But at the end of the day, I am going to have one video on ACLS review for my advanced folk. BLS folk, you would definitely get something out of it. It's worth watching. But we'll get to that video here another day. So thank you again. Be COVID free, be safe, be healthy, and we'll see you on the next one.